All right, let's talk about a scenario we've all seen. A longtime patient, usually someone over 50, comes to your counter describing a sudden, absolutely debilitating stiffness. This could be polymyalgia rheumatoida, or it could be its much more dangerous cousin, giant cell arteritis. Today, we're going to break down exactly what you, as a pharmacist, need to know to manage the therapy and, most importantly, protect your patients. So, here's our game plan. We'll start with what these patients actually look like when they show up. Then, we'll get into the tricky part, diagnosis. After that, we'll dive deep into the cornerstone therapy, corticosteroids, and the crucial job of managing their toxicity. We'll wrap things up by looking at the other agents you're probably going to see on their prescriptions. Okay, so what does this actually look like in practice? Let's start right where we live, the pharmacy counter. Because honestly, recognizing those classic signs is your very first chance to make a huge difference for someone. Just picture this for a second. A 72-year-old patient, maybe someone you've known for years, comes in and tells you this. We're not talking about minor morning aches and pains here. This is a profound, can't get out of bed kind of stiffness that just came out of nowhere. What's running through your head? Well, that is a textbook presentation for polymyalgia rheumatica, or PMR, and it's really closely linked to a much more serious condition, giant cell arteritis, or GCA. In fact, a lot of experts think they're really just 2 points on the same disease spectrum, and you'll notice both of them typically hit folks over 50 and are twice as common in women, just like the patient we're talking about. Now, this is where things get really critical. Telling the difference between PMR and GCA isn't just some academic exercise. One of them is a true medical emergency, and the questions you ask at the counter can literally help spot those red flags. The whole key is knowing which questions to ask. You see, with PMR, it's all about that awful pain and stiffness in the shoulders and hips. But the GCA symptoms, those are the real alarm bells. If a patient mentions a new kind of headache, or that their jaw hurts when they chew, or, and this is the big one, any kind of visual disturbance, that's your cue. That could be vasculitis, and the clock is ticking. And here is exactly why you have to ask those questions. Up to 60% of patients who have GCA also have PMR symptoms. That huge overlap means your simple question about a headache or blurry vision isn't just good practice, it could literally save their sight. So let's be crystal clear. If GCA is even suspected, it is a medical emergency. This quote right here is basically gospel for a reason. High-dose steroids have to be started immediately to prevent permanent blindness. The biopsy to confirm it, that can wait. It'll still be positive for a couple of weeks. The patient's vision, on the other hand, cannot wait. So that brings us to the mainstay of treatment for both of these conditions. And when we're talking about therapy for PMR and GCA, we are really talking about one class of drugs. Look, your patients have probably already tried over-the-counter NSAIDs, and they've probably gotten little to no relief. That right there is a huge clue. Systemic corticosteroids, like prednisone, are the only thing that's really effective. In fact, the response in PMR is so fast and so dramatic, we're talking improvement within days, that if it doesn't work that quickly, the prescriber should probably be rethinking the diagnosis. Now, for straightforward, uncomplicated PMR, the starting dose of prednisone is usually pretty low, somewhere in that 10 to 20 milligram a day range. But for GCA, look at that difference. We're talking 40 to 60 milligrams a day. That's a much higher dose. And it's not for symptoms. That is an aggressive, sight-saving dose meant to stop irreversible blindness in its tracks. Here are some absolutely critical facts you need for counseling for setting those patient expectations. First, this is not a short-term therapy. We're talking 1 to 2 years minimum. Relapses? Yeah, they're common, so prepare your patients for that. And some people might need low-dose steroids for years, maybe even indefinitely. Oh, and a key point for GCA, alternate day dosing is a no-go. It's just not recommended because it's linked to a higher rate of relapse. So, this long duration of therapy leads us right to the most important part of our job as pharmacists. We know these steroids work wonders, we absolutely do, but we also know they come with a hefty price tag. Preventing that toxicity, that is where we can make the biggest difference in our patients' lives. Here is a simple, proactive, 3-step approach you can use. Step 1, protect their bones from day 1. Make sure they're on calcium and vitamin D, and don't be afraid to advocate for starting a bisphosphonate early. Step 2, monitor everything, blood pressure, glucose, weight, be vigilant. And step 3, educate, educate, educate. We have to empower our patients to recognize and report those key side effects. I want you to think of this slide as your go-to counseling script for every single patient starting long-term prednisone. The absolute essentials are take it with food, you can never stop it abruptly, you gotta watch for the weight gain and mood swings, report any vision changes or signs of infection right away, and always, always talk about bone protection with calcium and vitamin D. Okay, but what happens when the side effects are just too much to handle, or the patient just can't seem to taper off the prednisone without their symptoms coming right back? Well, that's when we look at bringing in some backup. These steroid-sparing agents, as we call them, are really reserved for specific situations. If a patient is having major toxicity issues, if they're relapsing over and over, or if they just get stuck at a prednisone dose above about 7.5 milligrams a day, you're very likely to see one of these other drugs added to their regimen. Let's just quickly hit the most important counseling points here. For methotrexate, it is all about that once-weekly dosing. You have to hammer that home. For low-dose aspirin, it's about that risk-benefit discussion on bleeding, especially with prednisone on board. And for a drug like tocilizumab, the big one is infection risk. You have to make sure they've been screened for TB before they start that first dose. And that really brings us to our final thought for today. You know, PMR and GCA are diseases of aging, and our population is definitely getting older. The need for long-term corticosteroid therapy isn't going away anytime soon. So the real question for all of us is, how can we evolve our practice to be even more proactive in managing these patients, in minimizing the harm from these life-saving yet incredibly challenging medications?